Excellent. Thank you very much, Edward and team. And my name is Tasir. I'll be hosting today's session, and it's my warm pleasure to welcome all of you to our fourth grand rounds for the year under the Middle East Academy of Otolaryngology and associated with Tarabichi Healthcare. So we know it's different parts of the world at different timings, and all your times are extremely precious to yourselves and your families and your patients. So thank you very, very much for making time this evening to join us for our fourth session. I wanted to just say a couple of words before I introduce our moderator and panelist, who will then introduce our esteemed speaker. Um, this is now our fourth session, as I mentioned, for our Grand Sound series, and really the vision behind this is to create a free for all virtual, easily accessible platform for people across the world. We've had numerous sessions and meetings and conferences here in the Middle East canceled or postponed over the last couple of months. So series and platforms like this just allow us to continue collaborating, talking, and exchanging ideas and knowledge. So I think these kind of things, although maybe spurred by COVID, continue to be relevant as months and years pass on. So it's a warm welcome to each of you. I'm going to place in a link to our YouTube channel. So feel free to subscribe to that and share that. And this session is going to be live streamed to YouTube, to Facebook, to a few other platforms as well. Um, and The last few sessions, we've had people from all over the world join us. And if you can't join us live, that is a way to ensure that you didn't miss what we discussed. Okay. So I want to introduce our moderator and our panelist. First of all, I'll introduce our esteemed panelist, Dr. Jebreel, Dr. Alaeddin Jebreel, who's a consultant head and neck surgeon in the Department of Head and Neck Surgery at King Faisal Specialist Hospital in Riyadh, Saudi Arabia. On a personal note, he's also has another hat of complex pediatric otolaryngology. So I've collaborated with him in that space. He's a wonderful colleague, a very smart and nice human being. So I'm very happy to have him within the panel of today's session. And our moderator for this evening, who I will hand over to shortly, is Dr. Hussain Alsaffar, who is an otolaryngologist, head and neck surgeon specializing in head and neck oncology and microvascular reconstruction. He completed his medical degree at King Faisal University, followed by a residency um, at Western Ontario in London. So Western University in London, Ontario. He then pursued a 2-year fellowship in head and neck oncology and microvascular reconstruction at the University of Toronto. After that, he joined the Ottawa head and neck oncology team, where he established himself as a leader in advanced oncological surgery and complex reconstruction. From 2018 to 2023, he then served as the program director of the Otolaryngology Head and Neck Surgery Residency Program, and as fellowship director of the Head and Neck Oncology and Microvascular Reconstruction Program. He also chaired the weekly Head and Neck Mucosal Oncology Tumor Board, advancing oncology care and education. He's now at the King Faisal Specialist Hospital here in Riyadh, where he's a consultant, and he's widely committed to clinical excellence, innovation, surgical education, and patient-centered care. So it's an honor for you to be part of our panel and moderating the session, Dr. Hussain. Thank you very much for your time, and I'll hand over to you.
Um, as a lead, as he's one of the leaders in North America, Canada. He is a head and neck professor, full professor at University of Toronto and at Department of Head and Neck Oncology. He has major focus in major head and neck surgeries, microvascular reconstruction. He's been involved in so many positions along the way at the hospital, as nationally as well. He's currently the president-elect in the Canadian Association of Head and Neck Surgeons. He has a huge role, and he's one of the pillars of the head and neck program back in my days and carried out forward. He graduated so many fellows. I would say more than 20, probably more, over the last 20 years. And his legacy has been carried away across the globe, probably. What strikes me about Dr. Higgins is his strive for innovation. He's always thirsty for more. I remember when we first learned about supraclavicular local regional flap, and we started experimenting and doing it together. And I owe him this is the person that I learned from. I learned with as well. And he's very humble, very innovative. If you see him operating, he's like a painter painting a canvas, like amazing. So I think he's giving us he's back in the days, like over 15 years. He has a focus on intervention thyroidology. Back in the days, he has special interest for thyroid surgery, and he's gonna give us his thought about the new updates and innovation in thyroid intervention. Without further ado, Kevin, thanks for finding the slot in your busy life. I think you're muted, Kevin.
Thank you, Hussain. It's an honor and privilege to be here. I wish it was in fact in person. And my heart and prayers are to all of you in the Middle East, and hopefully better times will await us, and we can all meet and learn from each other together. And to see Hussain remotely, it brings me joy. Hussain was an absolute superstar, a wonderful human being, an even better friend. And one of the best things about having trained and educated over 40 international fellows now in my career is to see them, like a proud parent, go off and do amazing things in their own right. So it is the best part of my job, is actually the fellowship mentoring. So with respect to today, I'm hoping to share with you my journey with respect to interventional thyroidology. And it has to do with the fact that I think to be at the vanguard of your specialty as you move forward, to stay current, to stay innovative, and to have your curiosity piqued always, because it's too easy to get in your safe comfort zone, in your lane, but that really limits you, I think, as an individual. So I'm hoping to share with you my journey and in my interest in endocrine oncology, in that if you're going to be referred a patient, you should be able to offer them the full spectrum of appropriate care and care pathways. So having to learn and to do, continuing medical education is part of the lifelong journey for the head and neck surgeon. So I'm going to share my screen, and I'm hoping to make this as innovative as possible. And as interactive as possible. So we're going to talk a little bit on interventional thyroidology. We're going to talk a little bit with respect to ethanol. So ethanol ablation is really best suited for lesions that are obviously cystic or anechoic. And so the pathway for interventional thyroidology really starts with an understanding of ultrasound and basic ultrasound techniques. You start with your ability to image with regards to the acquisition of steps. It obviously starts with ultrasound familiarity with the principles, the fundamentals of ultrasound, the physics, etc. There are a wide variety of courses offered around the world. I happen to take a ACS course in the United States for credentialing, but there are many courses with CME events available. So you gain an ultrasound appreciation, and that moves towards needle biopsy capability. That's ultrasound guided. Moving beyond that to core needle procedures, etc., and then starting to get into procedural intervention. And I started with ethanol sclerotherapy being a wonderful option for the cystic nodule. In fact, it's my go-to. And the way I deal with cystic nodules, we first do a ultrasound guided evacuation, sending those the cyst contents usually will come back as acellular or foam macrophages consistent with cyst contents. I'm always very careful and circumspect with regards to, is there a mural wall? Note the characteristic of the ultrasound aspirate, that it isn't bloody, etc. And if that comes back and it's still, as I would, call it, a very low risk, sort of, Bethesda 1 anechoic TIRADS 1 type nodule, then we proceed with an option for sclerotherapy. We usually inject about 50% of the volume of the aspirate, which was noted at the first presentation. I typically allow about a 2 to 3 minute dwell time, and then personally I evacuate the 99% ethanol. I'm just a little bit worried that sometimes you can get some degree of leaching. It's more of an issue with metastatic nodal aspiration or ethanol sclerotherapy, less so with a thyroid with a denser capsule or pseudocapsule than a node. But I'm still a little bit reticent about any ethanol that could egress that into that central compartment and make eventual surgery harder. So that's ethanol. It's just as a little teaser in terms of the cystic nodule. A wider application is radiofrequency ablation. So with regards to the basic techniques, we're going to focus mostly on radiofrequency and not talk about microwave ablation. It tends to be done the way I do it, as was popularized by Dr. Beck in South Korea, who is really the innovator of this treatment, who's in fact an interventional radiologist. But it tends to be a central approach with a transismic approach to minimize the number of passes through the thyroid, as opposed to multiple pincushion approaches, which can be a reasonable option, especially for very large multinodular goiters. I try and limit the number of in and out access and try and think about one access, usually through a transismic approach. And it also minimizes this sort of Swiss cheese rendering that can happen with multiple percutaneous passes, because one of the complications, which I will discuss, is nodular rupture. And one of the things that predisposes to that is multiple insertion points. So, the transismic approach really is a moving shot technique where the probe is passed to the distal reaches. You try and formalize compartmentalize the nodule into an ablation unit. I tend to go usually from caudal to cephalad, and the needle is or the probe is advanced to the furthest reaches, and then as it's withdrawn, the electrode is activated, and you see a series of hyperechoic bubbles that allows the area to be tracked in terms of the progress. It's very obvious as you withdraw with your moving shot technique, and it also allows for dispersal of the heat energy to minimize the discomfort to the patient, but also minimize any thermal spread to areas outside of your intended target. So I've already spoken to that. One of the things that I also try and do, which lends itself really quite well with respect to the treatment of the toxic nodule or the hyperfunctioning nodule, is to think about this technique of radiofrequency as almost like a targeted embolization procedure, in that if you can target feeding vessels, whether it's a toxic nodule or not, it will help with the overall uniform shrinkage of that nodule. So when we're doing our ultrasound, I'm very careful to do a color flow Doppler assessment of dominant feeding vessels, and I tend to target those areas first at the beginning of my ablation, and then proceed with the nodule ablation compartments as I previously described from the previous slide. And certainly in the area of toxic nodule management, it's all about this vessel treatment, because otherwise you're bound for failure if you simply treat the nodule itself. Because remember, a toxic nodule is effectively a clonal tumor mass and will regrow much more readily than follicular nodular hyperplasia. This is the setup, which is very easy to do, and it's, if people are interested in starting their own programs, please reach out to me. I would love to help with I'm more than happy to share our checklists, our patient information pamphlets, pre and post procedural information packages. I'm all about this dissemination of information, so please reach out. But it's fairly easy. You don't need a large footprint. The only, additional equipment that we needed to get beyond, procedural chair and the ultrasound, but was a pulse oximeter and a capnograph. We monitor the patients. We do it under local anesthesia with a slight degree of twilight anesthesia. We typically give some degree of minor tranquilizer, usually either a diazepam derivative like Xanax, and it's dosed to the patient's anxiety, as well as effective local nerve block and cervical plexus block, which is all part of the acquisition of base skills that I was to you acquire the technical nous of ultrasound, then needle biopsy. With that, you can start to use local anesthesia with your biopsies, and then cervical plexus blocks are quite easy to do patient surgery, as it seems to help with the postoperative analgesia and moving the patients through an ambulatory care pathway. So that's all we really needed to do in terms of our footprint and the equipment that is required. It's not particularly onerous. And then, one of the things that we've developed and played with is the ability to read probe tip is, because it's all about where that probe is, because you're putting an 18 gauge electrode in proximity to trachea, recurrent nerve, carotid sheath, etc. So you need to know where that is at all times. And one of the ways we do that, especially with a long axis approach, it's very easy to have that electrode array go out of, basically borrowed from our interventional radiology colleagues and use a ultrasound biopsy guide, which ensures or guarantees that coplanarity of the electrode in complete phase with the long axis of the probe. And that's helped dramatically in terms of our comfort to want to progress and develop. So these are a couple of photos. On the left screen, you can kind of see the hyperechoic bubbles that you are rendering. The far right, you're seeing the so-called danger triangle, which entry of the recurrent laryngeal nerve in the tracheoesophageal groove has to be respected. So these were all embedded videos. They don't seem to be playing on this platform, so I'm not going to worry too much about it. Proof is in the proverbial pudding. I would have loved to move through the nodule, but also to see it's almost like a meteor shower of all these hyperechoic bubbles that are emitted from the frictional heat caused by the electrode tip as it's continually moving and continually being cooled by ice saline. So starter case, as it were, you want to find that nodule that is benign. Some people have pushed this into the realm of cancer. I tend to really appreciate benign nodules for this. It seems to be the largest pool, especially multinodular cases. Better, but the perceived benefit is more limited because it's all a proportional volume decrease, and the patients are less impressed, as are you as the treating doctor. But also smaller nodules, it can be hard to get the complete tip in. Any complex anatomy. You want to avoid significant retrosternal projection, ideally mid-pole. You want to avoid superior versus lower. You go where the nodule is, but the ideal case would be mid-pole. I insist on 2 prior biopsies. Determinate nodule, sort of a Bethesda 3 and 4. I do insist on genetic profiling with your choice, whether it's ThyroSeq. I tend to use Afirma Expression Atlas because of the sensitivity and specificity profile of that assay and my familiarity with that. Somebody who is hyperalgesic, who gives off the patient who is hyper aware, highly anxious. Don't select those patients as your first pass, in my opinion. Pacemaker is a relative absolute contraindication, although you can use bipolar electrodes and safely ablate patients with indwelling pacemakers, and anticoagulation needs to be avoided in usual standard 3 to 5 days. or 7 days for antiplatelet agents, etc. And you have to have the right patient who's willing to put up with any potential issues and troubleshooting, etc. And so if we move forward, it's very safe. The twinned radiofrequency and ethanol allow you to offer a significant resource to your referring either fellow surgeons, whether they're ENT or general surgeons, or endocrinology, family practice, etc. It's like everything we do, it's all about careful matching the procedure for the patient. It's got to be the right fit. And you want to respect your learning curve. You want to carefully audit and track your own patients. And then the last thing that you need to move forward with is following these patients. You have to prepare this patient that it's not necessarily immediate, although as I gained experience, when I see the patient at that first month, you can often see very rapid shrinkage, and then it tails off over a period of 8 to 12 months. But you're selling them, or you're explaining to them, I should say, that this is a 8 to 12 month journey, and to not be expecting miraculous changes immediately, although we often do see that. The other cautionary tale is that when you're ablating these patients, the nodule is not disappearing, and you're getting 80% plus volume, three-dimensional ellipsoid volume shrinkage, but you still have a nodule that sometimes the patients can palpate because the texture becomes slightly more fibrous, a little bit more firm. So if you have the patient who's constantly feeling their neck and is hyper aware, you're careful whether they're the right patient, but you're also telling them and anticipating that change in texture, etc. The other really big piece of this is you need to have your ultrasonographers in the area who are reading follow-up imaging and ultrasound are aware that the post-RFA nodule looks unusual. It looks oftentimes suspicious. So, I am typically following these patients myself, certainly over the year, and am mapping them. And then if the patient is moving forward for a clinical radiology follow-up, then it's a radiologist who's familiar with the post-treatment appearance of ablated nodules. So the experience really was driven in Asia, and especially in South Korea. Their success rate is very strong, especially if you define it as a volume reduction of 50%. It's almost 98% of patients achieve that. And why do we care about 50%? 50% seems to be the key number where the patients, especially if they have compressive symptoms, start to notice a significant improvement in their compressive features, as well as patients who are more cosmetically aware, or you're doing it, for instance, for that isthmic nodule in a younger patient where it's very visible and aware, especially when they're swallowing, they're self-conscious about it. It's a 50% volume. You tend to get significant flattening of that contour, and the patients become very delighted with their eventual appearance. The other thing that you need to respect is the learning curve. You need to take your time. You need to be technically able. You have to be able to troubleshoot. You have to be effective with your regional anesthesia, quite honestly, because it's all about getting energy into the nodule. And you can see with the slide to the right that, it takes some time that people are getting better, but they start about, 50% of patients getting an 80% reduction to, 70 to 80%, which is sort of what is discussed from large series in large institutions with a significant amount of RFA capability. That's what we're all shooting for. But we have to be reasonable, and it's going to take some time to get to that capability. So it all goes back to that slide previous that was shown, that you want to have the right patient. Then it would be very important for me to talk to you about complications. So the good thing about this technology is it's very safe. But once again, it has to be matched with the right patient. So in terms of recurrent laryngeal nerve injury, it's genuinely factored to be safer than partial thyroidectomy surgery, with some degree of voice change noted in fewer than 1% of patients, which is on par, if not better, than partial thyroidectomy. Nodule rupture is sort of the feared complication, and is an aseptic effect of basically the nodule becoming necrotic, but not an aseptic necrosis. So it typically does not need to be treated with antimicrobial therapy. It just needs to be patiently managed. I'm going to touch wood. I've done 100 RFA cases to date. I'm touching wood as I mention this to you as a superstitious Irishman, that it has not happened. But if it does manifest, it's managed not with antibiotics, it's with careful patient care, local wound care, and steroid medication. The biggest issue that I found is anxiety and having the patients comfortable enough with the procedure. And that is a combination of the right anxiolytic with the right degree of local and regional anesthetic that is delivered to the patient. And then the long-term success rate is completely linked. So you can see, in the middle, you have the original pre-RF, or the far left, the original pre-RFA nodule size with a volume of 18. You have a early shrinkage, and then down the road you basically have an ablated area that remains, almost like the yolk in the egg, but then you have the peripheral area that was undertreated, and that regrows. So that's what we want to be careful with, and that's where it's all about the energy. So it's all about transferring the thermal energy from the electrode into the nodule. And so what I do is I generate a cubic centimeter volume of what that nodule is. And then I figure out how much energy, what is my goal in terms of when I stop ablation. Part of it is patient tolerance. Part of it is the ablation compartmental units that I discussed as you're moving from caudal to cephalad. But I'm also have in the back of my head a target in terms of the amount of energy. And I tend to keep that electrode there until I get the energy that I want. And that's where the feedback comes in, because the energy that's delivered has to do with the consistency and the internal resistance of the nodule. And that's also where the technical piece is. So if it doesn't seem to be transferring, or if it's very time laborious, then I tend to affect the number of watts that I'm putting into that machine to make the procedure more effective. So more watts allows for a larger degree of joules transmitted into the nodule. So you want to start in that sweet spot in terms of size. You want to be a little bit wary of the toxic nodule, because the refractory or recalcitrance tends to be higher with those. The effectiveness of radiofrequency is lower with toxic nodules. They tend to be an early referral source because it's such an effective treatment. It's a one-stop shop. boom, it can be very quick, especially if you can find the feeding vessel, but you have to prepare the patient that it may require more ablation and a chance of having a return of their thyrotoxicosis. So you want to find the right nodule, mid-pole, surrounded by normal thyroid tissue. You want it to avoid the danger triangle. There are techniques as well that I employ to improve the zone of operation and the safe zone of operation capability. And that has to do with the liberal use of dextrose around the trachea, especially with the transismic approach, because your probe can be very close, especially if it's a very thin isthmus. You're going to be very close to the trachea. Now, the electrode doesn't transmit any energy through its shaft. It's only at the tip. But if you're withdrawing and reinserting, etc., there's a tendency for some thermal energy to potentially be transmitted as you move in and out. So you have to be careful with the skin. You have to be careful with the trachea. So if you put dextrose, it increases that zone of operation. Similarly, in the area around the danger triangle, and even more importantly, laterally around the carotid sheath in vagus, you can gain 1 centimeter plus and really increase the safety margin as you're ablating on the lateral side of the nodule or inferiorly reference to the innominate artery. So, that's it for my slide deck, Alaeddin and Hussain, and I'd love to have a Q&A interactive and pick my brain as you desire. And thank you. I'll stop sharing.
That's great, Kevin. Thanks very much. I've learned a lot of it. I think you spoke about limitation of introducing this concept at institution level as well as to your patient as well. And there's sometimes some challenging, even in intervention radiology in general, even from frequency, ultrasound, and to have this kind of setup required time and kind of clear communication with your institution and jurisdiction. I think I posted earlier, and I forgot to mention that if anybody has any question, there is the webinar chat. You can type your question. I'm happy to read it. While we're waiting for that, I have a question for you, Kevin. I think obviously there are a lot of controversy in malignancy when it turns to whether microcarcinoma or not to be used. But for benign nodules, do you have an upper limit where you say this is not for it? And what would that be?
Yeah, so that's a great question, because in terms of the number of patients coming into you for management, the vast majority in my practice will be multinodular. So I never ablate on both sides the same sitting. Just because I'm careful with regards to the risk of a bilateral cord injury, which is obviously very small, but still most providers are very reticent to offer bilateral ablation. Some experienced practitioners would, most wouldn't, especially at the genesis of your program. The other piece about this is, obviously the multinodular goiter is the patient you'll probably see the most. The issue is that to get that success rate of an 80% shrinkage, you could go from an 8 centimeter nodule, that might mean that they're still 4.5 centimeters size and they're getting an 80% volumetric reduction. So you have to be careful with the patient, because it's not going to mean a disappearance. It will likely lead to an improvement both in how it looks and how it feels. but sometimes it's not enough. It's like sleep apnea, the CPAP may get you better, but it won't get you enough, or a sleep surgery will get you close, but still dependent on CPAP. It's a similar concept in that they may get improvement, but they're still, beyond the threshold of you fixing their problem. The other piece of that is, and I've started to develop more expertise with more advanced nodules and retrosternal, but I didn't do that, for about 20 cases. And the other piece of that, it has to do with the energy. So in order to get enough energy to get the shrinkage that you need in large nodules, it can take an inordinate amount of time. So it's the clinician's time, but also the fact that you have to have a patient who's willing to, submit to anywhere from 30 minutes to an hour of lying still, dealing with the anxiety of this procedure. So if you're good at your anesthetic and your anxiolytic, you can do these cases, but you have to be patient. You have to be familiar with the machine and confident to get the energy where you need it as quickly as you can to minimize the procedural length. Because from a practical standpoint, it may be quicker and more expedient and more guaranteed to offer some sort of partial thyroidectomy. But this is where you having the skill set to offer alternatives makes you a key player in the field, right? So, but that's something I'm very careful with.
Thanks, Kevin. I think Dr. Jebreel has a question.
Thanks, Kevin. I really appreciate this really cutting-edge new approach to managing this common condition. I have a twofold question, if you don't mind me. The first is, how did you feel this impacted your routine practice? So let's say before you started doing this and after. Obviously, there is a big advantage to the patients. I'm sure maybe your waiting list got smaller. Your criteria for listing patients for surgery might be different. Do you have any sort of measurable impact on the practice? And I'm sure your practice is not a standard thyroid surgeon, but if you've had any calculations of how it affected you. And the other question is, and we know that doctors are a bit difficult to convince. Did you have any sort of resistance of adopting this by other colleagues, endocrinologists, by maybe MDT, tumor board members, or I would assume that patients were probably more open-minded to this than maybe some of the medical colleagues, if your practice is similar to mine.
Right.
Thank you.
Yeah, a great question. So I'll tackle the first one. So how has it impacted my practice? So in Canada, it is universal healthcare, universal access. So it's not a private-public blend. It is effectively one system for all patients. And so wait times is a huge issue. So the ability to offload patients is attractive. Now, interventional thyroidology and RFA is not funded. So this is a self-pay sort of world for the Canadian patient currently. Now, some jurisdictions, certain provinces, the provinces are starting to pay for this technology. In Ontario, it was a proof of concept. In fact, myself and 3 others have just recently petitioned the government for funding consideration because and in fact have a cost effectiveness study that will be published shortly showing it's an obvious no-brainer for a public payer to take this on because your patient quality of life measures, societal perspective, patients are not missing work, very little downtime. It's easy for the public purse to fund this. So that's a stay tuned piece. With respect of how has it affected my individual practice? Well, for instance, from the spectrum of cases, I don't operate on cystic nodules at all anymore. Zero. I am almost 100% effective with ethanol treatment in these patients. And maybe it requires more than one treatment, but it's very easy to do. It's very easy for us to source the 99% ethanol. It really is only limited by the patient's tolerance because it's uncomfortable to get ethanol treatment, especially post-procedural. Hence why I've transitioned to a withdrawal of the aspirate after the original sclerotherapy. With respect to other players in the field, in the American or in the North American Society of International Thyroidology, the NASIT, there's lots of players in the field, right? There's endocrinologists, there's ENT surgeons, there's general surgeons, interventional radiologists. And so everybody so far is playing in the sandbox. I don't have any issues in Canada because endocrinologists do not want to do procedures. Very few even want to do diagnostic ultrasound. So this is right now not a consideration. And other providers locally, the problem with the RFA is it's a system build out. So for us, the technology is expensive. Partially it's offset by the patients out of pocket, but it's also philanthropy. So we had some major donors who facilitated us getting this program up and running. So that's from the heavy lifting side. From the institutional side, we had to get a procedure room designation to allow for general anesthesia, similar to outpatient dentistry. That was a little bit of navigation from a, patient quality and safety piece. But it's not anything that wasn't insurmountable with some degree of, buy-in on my part and time that I was willing to spend because I was such a big believer in this approach. And then the last piece was MDT, etc. So, I'm very careful to avoid this for malignancies, although the most recent 2025 ATA does allow for radiofrequency treatment of small nodules or microcancers, as well as active surveillance. It's a much more comprehensive guidelines that has recently been published. And then with respect to other pieces of thyroid endocrine care, I don't ablate nodes because it's similar to the small nodule. It's very hard. You can get very small 5 mm probe tips, but it can be very hard to successfully navigate and successfully ablate that area just because the zone of the operation is so tight and so small, plus the proximity to major structures such as the recurrent nerve. So if I have a patient where they have, for instance, recurrent well-differentiated disease, central compartment, if they have had multiple central compartment surgery and they still have thyroglobulin rise and still have ultrasound evident disease, those are patients that I consider for ethanol ablation that I do myself, as opposed to multiple reoperations, and I do not radiofrequency ablate them. And that is vetted by an MDT, yes.
Thanks, Kevin. I think people are shy to ask questions, so I have a follow-up question. So, like you said, you can get in about 9 months, you can get about 80% volume reduction. Did you ever offer reablation?
Yeah. So, this is so we have 100 cases to date. So we're actually going to be publishing our experience because I think the learning curve, obviously there's series of much larger scales in Asia, but from a North American rollout perspective. So I've not yet had to retreat. And, because when I we've audited and when we report on our results, we're almost 100% have achieved over 80% shrinkage. So we're, we're still early days in our experience, but we are to date being highly effective and some really impressive early results. Like I've been, I can tell you I'll share one case where I had a patient who had a retrosternal goiter. He was felt to be medically unfit. For one thing, he had previous radiation for head and neck malignancy, multiple biopsies, all confirmed benign nodule. But he had become increasingly dysphagic as a result of this large nodule. And so, surgical management of this would have been very difficult. He had also had a carotid endarterectomy, so the combination of previous lateral compartment dissection plus carotid plus RADS, it was like a no-fly zone for an open approach. And so I offered him radiofrequency, and he had, his nodule went to 3 centimeters basically by a month and a half. And he sent me a photograph from a famous steakhouse, Morton Steakhouse in the city, saying, Dr. Higgins, 2 weeks after the ablation, I was able to have the first steak that I've had in 5 years. So that was pretty interesting to see that. So, they're not all home runs, and you need to do a lot of hand holding, but some of the early experiences have shown pretty striking, dramatic improvements very quickly. But I always prepare, I under promise and try to over deliver, and that's helped me in my marriage as well.
I think you taught me that. Kevin, just a follow-up now. I probably in your 100th case, you never operated in any of those, but what is the literature says about like operating after ablation?
Yeah, right. So the literature would say that and having spoken with Jonathan Russell and Ahmad Kandil, who are and Ralph Tufano, some of the players with probably the largest experience in North America, they have not had any issues with reoperating on radiofrequency ablated patients. Now, ethanol cases are sticky. But many of us in the audience are patients who are surgeons who operate in the chemo RADS IO era where those necks are hostile. And so, it's, quite honestly, even a post-radioactive iodine thyroid case can be very problematic. So they caution it, but nothing that is insurmountable.
Kevin, if I may ask, your outcome measurements, obviously relying primarily on ultrasonic follow-up. How often do you rely on biochemical markers for the follow-up for these patients, especially with the toxic nodules? And do you think it's worth waiting for a while before biochemically you can see a response, or do you have to do it straight away?
Yeah, that's a great question. So with respect to thyroid indices, I do standard thyroid function testing at every time point of follow-up for the radiofrequency cases. And on one patient, I've had to put them on a supplement. The rest, and that's one of the attractive features, is the avoidance of thyroid supplementation compared to partial thyroidectomy surgery. So that's actually one of the selling points of this technology. With respect to the hyperfunctioning nodule, I partner with the endocrinologist. I will intervene when they tell me to. I order the blood work, etc. But it's when they think that there hasn't been a response. It's their comfort level, whether they're needing to start back on methimazole or PTU, etc. So they're the ones who are telling me. So it's a partnership.
Thanks, Kevin. I don't know if anybody has any other questions. I think we're right 8 o'clock at the dot. Thanks, Kevin. Really good to see you. I'm sure you're still biking. So Kevin, you guys, one thing you don't know about him, he's a great athlete. He bikes 365 days a year. I think he can count the days that he doesn't come with his bike. In the middle of the snow, nothing stops him, and that's just give you his personality. Like he's a go-getter personality, and that's something I learned a lot of, and I try to imitate him, but I can't keep up with him. So
well, you're making me blush, and my dear departed mother would be smiling, Hussain, with those kind words. But I am a believer in the strong mind, strong body, and I have found that the durability of the head and neck surgeon, endocrine surgeon, if you don't have a strong body to withstand the pressures and the long days, I've found it's my coping mechanism, and it's what's worked for me. So thank you for the attention, and thank you for the opportunity to share.
Thanks, Kevin. Hopefully we'll see you in live in October.
I very much hope to see everyone in person. It's a part of the world that I very much want to see. Lovely people, a beautiful land, and I hope to get there very soon.
Yes. Okay. Thanks, everyone. I think he has to go to the clinic.
Thank you very much, Kevin. Looking forward to seeing you soon, hopefully in the Middle East. And thank you, everybody. Thanks, Hussain, for this great moderation. Very, very lucky to have Hussain with us, Kevin. A great product of your program and an excellent colleague to have. So I think if there is no further questions, I think we can probably close this session. And thank you all. And looking forward to seeing you in our next Middle East Grand Round, which will be announced. So keep following our channels and Facebook page, and hopefully see you all soon. Thank you.
Thank you.